So good morning all. Welcome to today's OSCE on eye movement. So myself, Dr. Lakshmi, and I will be presenting along with Dr. Jyoti, and our moderators are Dr. Soumya madam and Dr. Sorry for the inconvenience. So we'll be having 30 questions, and each question will have 30 seconds. So question number 1, a 73-year-old woman presented with complaints of diplopia, change in gait, imbalance while walking, memory loss, behavioral changes, and diarrhea. Cognitive examination revealed a score of 21 out of 30 on MOCA. Eye examination showed the following. I'll be showing the video. A neurological exam revealed mild ataxia and gait, unsteady gait. So this is the video. So what is the phenomenology? Name the associated condition. And what is the treatment? The next question, a 72-year-old man very gradually developed gait unsteadiness in his early 50s. His imbalance was clearly worsened when he closed his eyes, and he noticed that his visual field was unstable for a fraction of a second each time he moved it. So this is the video segment. So here, patient's visually enhanced VOR is checked. And in the segment 2, head impulse test is checked. And in the segment 3, VOR suppression is checked. So this is the same patient. Limb ataxia is being checked. So what is the condition? Name the gene associated. The next question. So what is the abnormal eye movement shown in the video below? And name one condition associated with this eye movement abnormality. Next question. Identify the cerebellar nuclei marked as X. Name the abnormality due to the dysfunction of the structure labeled X in the picture. Next question. Identify the eye movement abnormality. Name two non-structural causes that causes this abnormality. Next question. So there are two videos of children with this characteristic eye movement abnormality. to mention the finding and name a genetic condition associated with this finding. The next question is a 21-year-old woman. She developed abdominal pain and nausea one day after laparoscopic appendectomy. She had received intravenous metoclopramide 10 mg and oral paracetamol 1 gram at 7 a.m. and 3 p.m. And at 9:30 p.m., she developed recurrent abnormal eye movements. On examination, patient was conscious, cooperative, and pupils were equal and reactive. So there was repetitive, involuntary, conjugate, upward, and lateral right gaze deviation associated with neck extension and increased blink frequency. So I've given two images. The first image is before treatment, and the second image is after treatment. So the question is, what is the phenomenon and what is the first line treatment of the condition? The next question is a 22-year-old girl presented with abnormal gait, impaired coordination, involuntary movements, and developmental delay. So what is the diagnosis? Name two condition associated with this. Next question. What is the diagnosis? Name two associated condition. See the video. So what is the finding? What are the anatomical localization? See the video. So a test is being executed. So this is the test. So what are the findings that suggest a central cause of vertigo? What does a positive head impulse test indicate? Next question. What normal physiological mechanism enable a motorcycle rider to maintain foveation while riding? The sub-question, which abnormal eye position results from a lesion in the indicated area of the brain? Here. The next question, a 22-year-old female presented with progressive gait difficulty, abnormal posturing of limbs, and progressive cognitive decline. The clinical examination is shown in the video. She was subjected to bone marrow examination. So the question is, what is the probable diagnosis? What is the bone marrow finding? Now the eye movements are being tested. So first the upward gaze. Now the downward gaze. Now the rightward and the leftward gaze is being tested. Yes, ma'am. There is upward as well as downward gaze restriction, whereas the sideward gaze restriction is normal. Horizontal is normal. Yes. Yes. The vertical movements are absent and horizontal is normal. So what is the probable diagnosis? What is the bone marrow finding? The 30-year-old man who suffered an acute stroke described the eye finding scene and identify the site of stroke. So this is slow motion of the cats are being tested. Now the patient is asked to close the eye and open. So the question is, describe the eye findings and identify the site of stroke. The next question, 57-year-old with myasthenia, acetylcholine antibody strongly positive. So this is the eye finding. So name the eye sign. Name the other named eye signs seen in this condition. So here the patient is asked to see the red dots. Now the patient is asked to take rest. And again, he is asked to look into that red dot. Now the patient is asked to take rest. So name the eye sign and name the other named eye signs seen in this condition.
Good morning to everyone. I'm Jothivanam and I will be presenting next 15 questions. Question number 16. This is an infant presented with features of apneic episodes along with cyclical alternating disconjugate horizontal gaze deviation. On examination, patient had frontal bossing, low set ears, nasal bridge, trapezoid mouth, and tongue protrusion was noted. An MRI of the brain was done. What is this sign on the MRI is called and what is the triad association with this condition? This is the video of the child depicting disconjugate horizontal gaze deviation. Question number 17. A 30-year-old woman had a 30-year-old woman had binocular vertical diplopia for 1 year, which worsened when looking to the left and looking up. There was no pain, no history of ocular surgery, trauma, sinusitis, or no other systemic illness. Upon examination, her head was tilted to the left and her face was directed to the right. Her post-duction test was positive. So this is the image of the uh, nine position cardinal directions of the gaze. And in E, which is the primary position, we will noting the hypotropia of the right eye. And in the C, we can see a restricted elevation in the abduction and downshoot of the right eye. Ocular examination. Okay. I can in this figure, ocular examination in the 9 cardinal directions of gaze, E is showing hypertrophy of the right eye in the primary position, and in C there is restricted elevation in the adduction position and downshoot of the right eye. In Postduction test is a test which is done. It's like a mechanical movement of the eyes, which will be done in the test to see for any restriction, madam. Eye with the object, like any forceps or any cotton, they will be moving the eye to see for any restriction. No, ma'am. Mm. 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 What is this condition called? How you will differentiate this condition from its mimicker? Question number 18 is taken from the case report published in Sri Chitra. It is a 11-year-old girl who experienced 4 episodes of right eye pain and ptosis and diplopia since age of 7. The first episode occurred in 2016 and resolved within a week with oral medications. The detail was not available. The second episode was in 2017. She had bifrontal headache and vertical diplopia and diagnosed with Colossus in Hunt syndrome outside. And it improved completely with the steroids and followed by a 3-month oral tapering of the steroids. In 2019, she presented to our OPD when she had right orbital pain, horizontal diplopia, partial ptosis, and restricted eye movements, and a sluggish pupil was present. And this time, imaging was done. In view of previously, she was improving with steroid. A pulse of steroid was given, which she completely improved. But in 2020, when the fourth episode, while on prednisolone and azathioprine tapering dose, she had a recurrence with right oculomotor palsy, preceded by a headache, photophobia, nausea, and vomiting. This is the video of the child, which is showing a right eye ptosis and the right eye ptosis and impaired adduction and elevation and depression of the right eye with normal abduction. Diagnosis of this condition and treatment of this condition. Question number 19. This is the video of the child. What is this condition? What are the subnormal movements seen? And what is the mutation associated and typical CSF finding associated with this condition? I'll play the video again. Question number 20. What is this phenomenon called and what is the mechanism of this phenomenon? Question number 21. What is this condition called? Name the triangle depicted in the MRI. Question number 22. What is the diagnosis of this condition? This is taken from a case report published here, where we are showing horizontal saccades and patient is not able to perform the horizontal saccades, horizontal movements. But other movements he is able to perform. Question number 23. What is name of this sign? And X-ray showing a scoliosis of the spine. Okay. Question number 23. What is name of this sign and what is significance of this sign? And here you have to you have to see the eyes. Here eyes. The movement of the eyes, the eye movements to be in the CT. This has a sign, madam. This is a sign, named sign. Yes, yes, madam. Looking at the eyeballs, what is the sign and what is significance of this sign? Question number 24. This is image of a patient. This is video of an image patient with BPPV. What is the canal involved and what is the maneuver used to treat this condition? Question number 25. A 45-year-old man presented with history of incoordination of all four limbs, slurring of speech. Upon examination, he is found to have dysarthria, limb and gait ataxia, and retropulsion. The family history is positive and MRI is done. His genetic study came positive for ataxin 2, in which type of the condition these characteristic eye movements are typically found. We are testing saccades. Question number 26. What is this condition called? Name two diseases associated with this condition. Question number 27. The patient is undergoing a cover uncover test. What is this condition? Question number 28. What is this sign called and mechanism of this sign? Question number 29. The first picture is a histopathology slide of a tumor and second picture denotes a triangle belt of an infectious condition. Identify the involuntary movements, involuntary eye abnormality which is seen in these two conditions. The clue is the first, if it is present in the first one, it has a good prognosis. And in second one, it has a intermediate prognosis. Question number 30. X is a arrhythmic repetitive downward and inward movement of the eye. This eye movement represents an alphabet when seen from a distance. It is mistaken for an eye movement Y, which is seen in the intrinsic pontine lesion. The X eye movement represents a warning sign of an acute condition Z and might require emergency surgical intervention. Identify the X, Y, and Z. X is a condition which is mistaken for Y. If X is present, the so we don't have the eye movements. in the X is a pseudo condition, madam. In this condition, patient will have arrhythmic repetitive downward and inward movement of the eye. X, like the condition. Okay. Okay.
So we'll be discussing the answers. So first question, 73-year-old woman who presented with diplopia, gait imbalance, memory loss, and on examination, the following eye movement abnormality was seen. So we have asked for the phenomenology and the associated condition. So here, yes, so the eye movement, it is the oculomastigatory myarrhythmia, which is a rare hyperkinetic movement disorder. It is characterized by rhythmic, synchronous, and repetitive contractions of both ocular muscles. So that typically produce a slow, pendular, convergent, divergent nystagmus at 1 to 3 hertz. And along with that, there will be mastigatory muscle involvement. So this phenomenon is considered pathognomonic for central nervous system involvement by Whipple's disease. So the treatment will be initial induction with IV ceftriaxone or meropenem or penicillin G for 2 to 4 weeks, followed by maintenance therapy, that is with oral trimethoprim sulfamethoxazole for at least 1 year. So alternatively, a combination of oral doxycycline plus hydroxychloroquine. So both continued for at least 12 months may be preferred. So the second question was of a 72-year-old man who developed gait unsteadiness, and there was a clear-cut that is worsening of his balance while closing his eyes. So here on VOR testing, so this is visually enhanced VOR. So visually enhanced VOR is patient is asked to see the nose of the the examiner, and the patient's head is tilted to the both sides slowly. So here we can see that there is saccadic intrusions on visually enhanced VOR testing. So eye is fixed. So this is the head impulse test, and it also clearly shows that bilaterally there is impairment. So corrective saccades are seen.
Basically, you can imagine like both vestibular nucleus are pushing towards each other. So if there is a defect in one, suppose if there is a defect in the right vestibular nucleus, it will move towards the left, and there will be a corrective saccade towards the opposite side.
And in the VOR suppression, so here the patient is.
Here the patient has to look at his own fingers. He'll make a fist like this, and the examiner will rotate the chair. So normally there will be no corrective saccade. But then if there is an impairment, there will be catch-up saccade.
And here
it is normal.
And the patient is having limb ataxia also. So the condition and the name of the gene associated with the.
So there is cerebellar ataxia here and vestibular ireflexia, and neuropathy is not mentioned in the history. So the syndrome with the constellation of features is suggestive of a canvas syndrome, and the gene associated is RFC1 gene. Other features are dysautonomia and neuropathy, which is not mentioned here. Not mentioned in our case.
Sensory neuropathy.
Yeah. In the constellation of cerebellar ataxia with positive head impulse test with visually enhanced VOR, in the background of ataxia, possibly this. Yeah, in the present, you're right, ma'am. In the presence of cerebellar ataxia in a long-standing history, you should consider this, and especially when the gene is associated, this becomes the most probable answer.
So next question was, what is the abnormal eye movement shown in the video and the condition associated with this? So here we can see that this is schizonystagmus. That is, one eye is moving up and the other eye is moving down. And the condition, so this is associated with craniopharyngioma and pituitary adenoma. The next question was to identify the cerebellar nucleus X. So this is vestigial nucleus, and name the abnormality due to the dysfunction of the structure labeled X in the picture. So here we can see that the vestigial nucleus impairment will cause hypermetric saccades, and the nodulus and uvula. The problem with nodulus and uvula will cause a central positional nystagmus and a periodic alternating nystagmus. And the floccular involvement will cause a saccadic pursuit, downbeat nystagmus, and impaired VOR suppression. And the dorsal vermis impairment will cause hypometric saccade. So next question was, this gentleman presented with the following eye movement abnormality. So identify the eye movement abnormality and name two non-structural causes. So the eye movement abnormality seen is downbeat nystagmus. So
downbeat nystagmus characteristically increases on downward gaze. So here they ask for any two non-structural causes. So you can write any of these two.
So SCAR6, SCAR27B, phenytoin toxicity, Wernicke's encephalopathy, hypomagnesemia, lithium toxicity. So these are.
Yeah, correct.
Yes, sir.
Convergence.
So the question was to mention the finding, eye finding, and name the genetic condition associated. Here we can see that the child is having monoocular nystagmus. And here we can see that the eye is deviated to one side associated with nystagmus on one eye. So the answer is paroxysmal. So in the first child we have uniocular nystagmus, and the second child it is paroxysmal monoocular exodeviation and nystagmus. So this is a clue to ATP183 related conditions. And the other causes of monoocular nystagmus include spasmus nutans, multiple sclerosis, and epileptic. As a part of epileptic phenomena also, this can happen.
Other conditions associated with ATP183 mutation are rapid onset dystonia Parkinsonism, Kappa syndrome, and alternating hemiplegia of child.
So next question was the 21-year-old woman who presented with abdominal pain, and after this injection with metoclopramide, developed this tonic eye deviation, and after treatment she became normal. So the phenomenon is oculogyric crisis. So the first line treatment is with anticholinergics, which include procyclidine, promethazine. So given intravenously in acute oculogyric crisis. The other options include piperidine, benztropine, and trihexyphenidae. The alternatives include antihistamines like chlorpheniramine and diphenhydramine. So the other question was two genetic condition associated with oculogyric crisis. So this is more common with tyrosine hydroxylase deficiency more than the sepiapterin deficiency. So next, this video is showing stereotypus initially, followed by tonic upgaze. So this child with abnormal gait, impaired coordination. So we have asked for a diagnosis and 2 associated.
The question should have been the finding here, the eye finding and the conditions associated.
The eye finding is paroxysmal tonic upgaze. So it's a type of episodic dystonia characterized by an upgaze movement preserving the horizontal visual axis. So this is associated with CAGNA 1A, GRID 2, childhood absence epilepsy, and chromosome 15 deletions, like both Angelman and Prader-Willi. So next question was identify the
finding.
Identify the finding and name 2 associated conditions. So this is blepharoconus, which is defined as brief repetitive contractions of the orbicularis oculi muscle bilaterally, and that are provoked by action of closing the eye, visualized as fluttering of the eyelids. And it has been associated with head injury, Arnold-Chiari malformation, juvenile Huntington's disease, brainstem lesions, including multiple lacunar infarct and congenital hydrocephalus with associated Parkinson's. Ma'am, eyelid myoclonia will be more jerky, and that is associated with epileptic abnormalities. And mostly this the eyelid myoclonus will be induced by like light or so here the blepharoconus is usually it is provoked by closing the.
How do you differentiate it from blepharospasm?
Blepharospasm is tonic contraction.
Forceful eye.
Forceful eye contraction. So this was the video. So here in the initial part, we can see that there is high amplitude, jerky nystagmus to one side, and on looking forward, there is fine nystagmus to the other side. So this is characteristic of Brunn's nystagmus. So it is coarse, large amplitude, low frequency horizontal nystagmus when the patient looks towards the side of the lesion. So so that is caused by the impairment of the central neural integrator, like cerebellar flocculus. And the second part, we can see that there is fine, small amplitude, high frequency nystagmus in the primary, that is straight ahead gaze, which intensifies on looking away from the lesion. So that is caused by the peripheral vestibular dysfunction. So the anatomical structures involved will be peripheral vestibular system and the cerebellar flocculus or the neural integrator. So this was the Hinds test, which include the head impulse test, nystagmus, and the test of skew.
Here it was normal. Head impulse test was normal. There was no nystagmus.
Yes. So this is a normal subject. And what are the findings that suggest the central cause of vertigo?
In the Hinds test.
In this test. Yes. So normal or negative head impulse test, direction changing nystagmus, and positive that is skew deviation is more suggestive of a central cause. And a positive head impulse test is characterized by corrective saccade, that is patient's eye lose fixation and then quickly correct back to the target when the head is rapidly turned. So this finding indicates a peripheral vestibular dysfunction, that is VOR will be impaired. So this, we have asked for a normal physiological mechanism that enables the motorcycle rider to maintain foveation while in this position. So here we can see.
So the mechanism is ocular counter roll. So basically, when you test for oculocephalic reflex, you are testing in horizontal. Like it is the movement which helps to focus the object of interest into the fovea while in horizontal movements, whereas when the eye is tilted, the same mechanism which helps to fixate at the point of interest is known as ocular counter roll. So ocular counter roll is a physiological mechanism, and when there is a defect, when there is a pathology, it is called ocular tilt reaction. Okay. So here the bike rider his head is tilted to one side.
Right.
So he has to foveate ahead. So the mechanism which helps him to focus at the object of interest is called as ocular counter roll. So in oculocephalic reflex, eye is moving in horizontal or vertical. But when the head is tilted, one eye should be elevated and intorted, and other opposite eye should be depressed and extorted. So that is the mechanism which helps to focus on the object of interest. Tilt. Yeah. So show the bike ride. So here head is tilted. So one eye should be the ipsilateral eye should be elevated and intorted, and the other eye should be depressed and extorted. So the pathway for this is this particular pathway.
Depicted, and here the side of head tilt. So the utricle will be stimulated.
So
and
the head is tilted towards this particular side, like left.
Right.
Right. Okay.
So when the head is tilted towards the right side utricle will be stimulated, and that sends signals towards the same side vestibular nucleus that crosses to the opposite side via the MLF and supplies the, for example, from the right side, stimulates the left side fourth nerve nucleus, superior, and the third nerve nucleus. So from the superior oblique, that is from the fourth nerve nucleus, supplies the right side superior oblique.
Superior oblique is contralateral, remember that.
And from the third nerve nucleus, it supplies the contralateral superior rectus. So superior rectus and superior oblique will be supplied. That is, this is the crossed pathway, and from the right side utricle, the right-sided superior oblique and superior rectus will be stimulated. And the same side, that is the left side, inferior oblique and inferior rectus will be stimulated. And what happens is that the right side superior rectus will cause elevation, and superior oblique will cause intorsion. And on the opposite side, the inferior oblique and inferior rectus. So inferior oblique will cause extorsion, and inferior rectus will cause depression. So this is the normal mechanism of ocular counter rule. So we have asked for the lesion when there is a lesion in the left utricle.
Or anywhere before the crossing.
Before the crossing, what happens is ipsilateral eye will be lower. So it should be upper normally, but here the ipsilateral eye will be lower and the contralateral eye will be higher. And
ipsilateral eye will be lower because the superior oblique and superior rectus are not being supplied. So lower the lesion on the ipsilateral side,
lower will be the eye. And the opposite, that is anywhere like a lesion in the thalamus. The higher the lesion, after crossing, higher the lesion, higher will be the eye. That is ipsilesional eye. So the mnemonic is high, high, low, low. The next question, so it was a 22-year-old female, and we have asked for a probable diagnosis and bone marrow finding. The eye finding, because of the spectacles, it was not clear. So the downward as well as the upward gaze was abnormal, but she was able to look horizontal. I mean, horizontally to both sides. So it is Niemann-Pick C, type C, and in the early part of the disease, there will be sparing of the horizontal gaze and selective involvement of the vertical.
So here is a young lady with supranuclear vertical gaze palsy and cognitive decline. So 22 years. So the differentials here will be, there's no mention about the Parkinsonism is there or not. So Niemann-Pick type C is a differential for young onset dementia, especially when the supranuclear vertical gaze palsy is there. Other differentials will be Kufor-Rakab syndrome and all. However, they have not given anything about the finger facial partial myoclonus or any other other features about Parkinson's. So Kufor-Rakab can also have vertical gaze palsy. Other diseases which can cause vertical gaze palsy, of course, PSP and other PSP mimics like Iglon-5 antibody disease, Whipple's disease, MAR2 encephalitis. All these diseases can cause supranuclear vertical gaze palsy. But in a young patient, this Niemann-Pick type C should be a consideration, especially with cognitive decline.
So here, so next question was a 30-year-old man who suffered an acute stroke. So here we can see that in the saccadic testing, there is saccadic intrusion saccadic hypermetria. So the diagnosis is right lateral medullary syndrome. So the eye findings are saccadic hypermetria to the right, that is ipsilational, hypometria to the left, which is contralational, and rightward ocular lateropulsion to the same side. Honors. There is honor syndrome also. So the main mechanism of this is from the so 57-year-old male with myasthenia. So the eye finding is chameleon eye sign, which is described in myasthenia gravis, that refers to a phenomenon where sustained gaze in various directions elicit intermittent exotropia on of one or both eyes. So this occurs due to fatigable weakness of medial rectus muscle, producing a striking appearance of the eyes moving independently like a chameleon sign. So other signs include peak sign. Other signs in myasthenia include peak sign, Cogan's lid twitch, and curtain sign. Pseudo, you know.
Question number 16. What is the sign in the MRI called, and what is the triad associated with this condition? The sign is called. These are questions.
What is the MRI sign?
The MRI is a molar tooth sign. No, this is questions not answered. Questions are being called. Yeah. It is getting shared. This one. This
No.
The molar tooth sign is seen in Joubert syndrome.
So this is called Joubert syndrome. Joubert syndrome is a disorder of primary cilia. The triad is hypotonia. Okay. Yes, ma'am. Joubert syndrome is a constellation of conditions. Uh, 17, force-duction test positive. This patient is having features of inferior oblique palsy, but the clue is force-duction test is positive. So the condition is Brown syndrome. Brown syndrome is due to mechanical obstruction of superior oblique tendon.
Yeah.
Okay.
It will mimic an inferior oblique palsy.
Yeah. 11-year-old child presenting with recurrent episodes of eye pain, ptosis, diplopia, and 4 episodes. The condition is recurrent painful ophthalmoplegic neuropathy. It is previously called ophthalmoplegic migraine. Now it has been termed by Headache Society as recurrent painful ophthalmic neuropathy. It is seen in usually children, and it's most common in females. The patient had right eye ptosis, impaired adduction, elevation and depression of the right eye with normal abduction. In the 4th episode only, she presented with characteristic features of migraine, madam. That previous episodes, the headache was not severe or not characteristic of a migraine episode. It was initially treated as Tolosa because she improved with the steroids. But while on steroids and immunomodulators, she had again recurrence. So, and this time she had a photophobia and a migraine typical feature. This time she was diagnosed the MRI showed thickening of the right third nerve with enhancement. 30% of the patients respond with steroids, but typical this anti-migraine drugs will be can be given, madam. The patient after that 4 years she is asymptomatic. And Kush. Question number 19. What is this abnormal movements called and what is typical CSF finding? This is a case of glutathione deficiency, and these are paroxysmal head-eye movements, which is seen in 38% of the patients. And typical CSF finding is a low glucose concentration with normal glycemia.
Paroxysmal head-eye movement.
Question number 20. What is this phenomenon? It is a Marcus gun. The patient, while opening the jaw, she is having ptosis on the left eye. Left eye.
When the jaw is, when the child opens the mouth.
Yes, ma'am. This is due to the aberrant connection between motor branch of trigeminal nerve and superior division of oculomotor nerve. What is this condition called? Name the triangle. This condition patient. The patient is having oculopalatal myoclonus, and the triangle is Guillain-Barré triangle.
Last part.
And this is a pimento sign which is seen in this condition. Question number 22. The patient. Sir, actually, in this triangle there is a dent in the. In any lesion in the Guillain-Barré triangle, that Guillain-Barré. No, sir. This is like pepper. Usually in this Guillain-Barré triangle, whenever there is a lesion, it will produce a excitatory effect on the inferior olivary nucleus, which will go into hypertrophy, and that is called given a sign called this pimento sign. Pimento sign. This is pimento, sir. This is like looking like this pimento sign. This one. Question number 22. The patient is having restriction of the horizontal saccades and patient is having X-ray finding, which is suggestive of scoliosis. The diagnosis is horizontal gaze palsy with progressive scoliosis. It is an autosomal recessive condition which is having due to ROBO3 mutation, which is a case published here. Question number 23. What is this sign called? The patient is having right MCS stroke and the conjugate eye deviation. This sign is called Prevost sign.
Deviated towards the side of the
lesion. So what is significance is that it is associated degree of deviation and stroke severity and poor prognostic outcomes. All these are associated. This is given in Historical Neurology, Annals of Neurology 2022 edition.
Yeah. Symbol.
That is given the sign which is called Prevost sign. Both, madam. Both interchangeable. Yes, madam. Affected hemisphere. Question number 24. What is the canal involved? So the patient is having predominant downgaze nystagmus. So according to the torsal downbeat nystagmus, according to Eval's law, the first law I want to signify. Nystagmus occurs in the plane of stimulated canal. Yes, madam. In these three canals, our patient is having involvement of the anterior canal. Because Eval's law of nystagmus, first law says nystagmus occurs in the plane of stimulated canal. So we have one horizontal canal and two vertical canals. Horizontal canal will have horizontal nystagmus. Vertical canals, anterior canal, posterior canal. Anterior canal will have downbeat nystagmus and torsion. Posterior canal will have upbeat nystagmus and torsion. And for 25 question, the patient is having ataxin 2 gene positive family history and he is tested for saccades which are so. This is hypometric saccades and cerebellar atrophy. This is ataxin 2 gene. So it is seen as SCA2, hypometric saccades. What is this? MRI showing cerebellar atrophy. Hypometric slow saccades, madam. Mitochondrial Pol G2 mutations. Even in PSP conditions, we can see, madam. Hypometric. What next? 45.
Yeah. Many DDs.
What is this condition called? Name to disease. With this condition, patient is having the full turning of the head when asked to fix an object.
First, and then eyes are lagging. So this is oculomotor apraxia.
This is oculomotor apraxia seen in the other conditions like oculomotor apraxia. What is this condition called? The patient is having nystagmus only uncovering. Otherwise, in resting condition, it is normal. This is latent nystagmus. Question number 28. What is this sign called and mechanism of this sign? The sign is round the house sign. And picture one, histopathology of tumor. The first one is a small blue round cell tumors, which is seen in neuroblastoma. And second image is the Tsutsugumushi triangle, which covers from Russia to Russia, Pakistan, and Australia. This is like predominant scrub typhus cases are reported here. So the condition is opsoclonus, which is a rare, opsoclonus is a rare manifestation of scrub, and it occurs during resolving phase of illness, and albumocytological dissociation will be there.
COVID-19 cases also reported.
Small blue round cell tumors, madam. Yes, ma'am. This is Tsutsugumushi triangle is a this scrub typhus, madam. This is that the parasite which causes tick oriented Tsutsugumushi. Tick, no, bacteria. Yes. So usually it will resolve without any immunosuppression by 12 weeks. Question X is a pretectal pseudobobbing, Y is ocular bobbing, and Z is acute hydrocephalus. What is difference between true ocular bobbing? It is like lesion in the pons, whereas pretectal it is lesion in the midbrain. how we will differentiate is true bobbing is a rhythmic movement, whereas pretectal pseudo bobbing is a arrhythmic movement. So our patient had X is a arrhythmic movement, so it becomes a pseudo bobbing. Bobbing is like a patient, the eye movement will be fast, downward will be fast with the slow upward movement of the eyes. So other features which can differentiate true true is with rhythmic movement, sir, whereas pseudo bobbing is arrhythmic movement. The other features which will differentiate both of them is the patient in true bobbing will have horizontal gaze absent, whereas in pretectal it will be preserved. Here vertical movements will be affected. Thank you.